Good afternoon, everyone. I understand that there are a lot of people out there, or a large number of people. I've been told there a lot, so maybe that's just to make me feel like I'm special or something here with this presentation. But I'm pleased that we have this format to bring this presentation to you today with regards to mechanical ventilation and the interaction with the patient. In my new role that I've started back in June of this year in the base hospital, I'm performing chart audits and pulling information out of those audits for the MAC reports, and they also help to support what we do in the following year in CME. And there are a number of things that I've seen in some of those audits which I think would make it useful to have this conversation with you today and address some of these things. One of the things before we start, I just let you know that there is about a 40-second delay between what I say and what you actually see me do and hear. So if you do send a question in, it'll be a bit of time before I actually get to the question. And on the point of questions, a number of you have sent some emails to me so that we can address some of these questions that some of you came up with when you were reading through some of the pre-reading. If you haven't had a chance to do that, by the way, there's some excellent articles in there that address and support with some evidence some of the things that we'll be talking about this afternoon as well. But some people have sent some questions in, and we'll deal with those in just a few minutes. And while I'm speaking on a specific topic, if a question comes to mind, you can send that in. And Sean Hackett is sitting here with Chris Anderson. They're operating all the technical side of things, and Sean will give me a signal that a question's come in, and we'll try to address that for you in a way that makes some sense. In addition, some of the things that you might see on the table, because I don't have the luxury of seeing what the scope is of the camera at this point, but there are a couple of devices on the table that I'm going to use as models to demonstrate a number of principles. And one of the models, and I just want to give credit to Paul Richard, who's one of our operations educators and here at Ornge. And this particular model, he built after I sent him a video of a colleague of mine that has a model of this on YouTube. Specifically, it's designed to demonstrate the effect of pleural pressures on lung volume and what you need to do as the individual who's managing the ventilation and what to do about that. So we'll refer to this as the P. Richard model, and I'll explain a bit more about it as we get into it and the concept that it demonstrates as well too. So where I started with this, thinking around this particular day and what I would cover with this, is that when we talk about mechanical ventilation and transport, we might think that we have these patients for a brief period of time. And since the ARDSNet trials in 2000 and the evidence that came out of that, we recognize quite well, and everybody accepts that, whether it's short-term ventilation or long-term ventilation, we appreciate that large tidal volumes can cause injury to the lung. And so therefore, for the last 17 years, we've been using 6 to 8 mils per kilogram ideal body weight tidal volumes. And that has worked well for us. And in the transport, in the context of transport, we use the same volumes as well. But there are other things that we do with the ventilator, and in the short period of time that we see the patients and have them on machines, do they have any effect in the long term of those patients? So are there things that we can do that can improve the length of time that they end up on a ventilator in the receiving facility in a critical care unit? Or on the opposite of that, are there things that we do that we may not be quite as aware of? And part of it might be just simply the limitations of the equipment that we use that result in long-term effects for that patient that we don't necessarily see, but they see 2 or 3 days later down the road based on where the ventilation started with that patient. So part of what we're going to be talking about today deals specifically with those things. And one of the things that I really want to talk about for some time was about patient-ventilator dysynchrony. And we'll speak a bit more about that as the session goes on. So what I'm going to do first off is I'll read you some of the questions that have come to me, or I'll read all the questions that have come to me. I'll give you some answers to them, and some of them will lead into the topics that we'll be talking about this afternoon. So I kind of feel like Dear Mr. Rogers here or something. So it's, but I appreciate the questions that came in, because it helps me appreciate how much interest is in these topics as well. So one of the questions that came out, which showed up a number of times in different questions that people sent, was the use of SIMV. And there have been a number of reasons why people suggest that SIMV is a mode that they like to use. One of the reasons for that is because there's a mindset that it decreases breath stacking as opposed to assist control ventilation. And When SIMV ventilation first came about, it was IMV back in the 70s, and at that time it wasn't synchronized with the mechanical breaths of the ventilator. So the ventilator was set up at 12 breaths per minute and the patient wanted 16. Those additional 4 breaths the patient got, they had to sneak them in somewhere between those 12 breaths per minute. And so you can appreciate already at that, with just not thinking about it a lot, that they could have a mechanical breath in their lung and now they want a spontaneous breath, or they've got a spontaneous breath in their lung and the machine says, well, it's time's up, it's time for my opportunity to give a breath. Gives a breath on top of the volume that already exists. So that type of ventilation, we didn't use that for very long before it migrated into SIMV. And SIMV has been around since the late 70s, and only recently, in the last 3 or 4 years, well, I shouldn't say only recently, some individuals in critical care units have stopped using it for quite some time because there are better modes for weaning patients off ventilators, because that particular mode was specifically designed for weaning patients off machines. So the idea was that you slow the respiratory rate down, you force the patient to take more spontaneous breaths. The thought was it strengthens their respiratory muscles, exercises their diaphragm, and you get a good understanding then of whether they'll manage okay once they're off the machine. So you can just keep reducing these breaths. If it was a surgical patient that had just been on for 24 hours, sometimes you went from 14 breaths per minute right down to 0, or CPAP, let them breathe on that for an hour, see how they do, and then extubate them. If they're on the ventilator for 2 or 3 days, then it was a progressive drop of respiratory rate, which was when the SIMV pace came in. There were quite a few discussions about whether SIMV and assist control, when you're wanting to control someone's full ventilation, which one of the two is better. And for the very same reasons that some of you prefer SIMV were the reasons why that people put forward why they liked SIMV as well. In one particular case, a colleague of mine used to always refer to it this way: if I'm giving somebody 14 breaths per minute in controlled ventilation, why would I assault them with another controlled breath when they just want maybe 2 or 3 breaths in addition to those 16 breaths per minute? And it seemed like a reasonable argument. And you know, there's the proponents of those who proposed that SIMV was a desirable mode over AC would use that particular argument. Interestingly enough, over the past 5 or 6 years, there's been a greater understanding of and looking at how does the mechanical ventilator affect the diaphragm. And one of the things that's come out of that particular research is that the diaphragm doesn't, and the respiratory muscles don't unload themselves when there's a mechanical breath occurring. So when you get the mechanical breath from the ventilator, if the patient triggers it or if it's a time-triggered breath, it doesn't unload the respiratory muscles in comparison to the spontaneous breath that they might have with pressure support. So the interesting thing was what we thought we were doing in unloading the respiratory muscles, or loading them for that matter, while we're decreasing the rate, wasn't exactly what was happening. In addition to that, investigators have also looked at this whole story about dyssynchrony or asynchrony, and you'll hear me use both terms, but they really mean the same thing. So dyssynchrony between the patient and the ventilator, and which mode had the most amount of dyssynchrony. And many of the modes, in fact, all modes have some dyssynchrony with the patient and the ventilator, but SIMV had more dyssynchrony than the other ones did. And one of the main things that happened with dyssynchrony in SIMV is what's called a double cycling or breath stacking, the way we typically have thought of it. Although when someone says breath stacking to me, there's 2 things that can mean. It could either mean that someone's breathing at a rate of, say, 30 to 40 breaths per minute, and it doesn't allow complete exhalation, so there's a continuous increase, dynamic increase in the lung volume, or the FRC. And the end result of that will be a lung that is full of gas at the end of expiration and has very little room for the next tidal volume delivery. So pressures rise if you're in pressure control, or sorry, if you're in volume control, and tidal volumes fall if you're in pressure control when that happens. But when the literature talks about breath stacking in relation to dyssynchrony with the patient and the ventilator, it's typically talking about 2 breaths that might come in back to back when there is an incomplete exhalation of the previous breath. So it's not like it's a continuous building of functional residual capacity as breaths stack on top of one after the other after the other. It's sometimes just 2 breaths together that are so close together that it stacks the volume up. And we know, because of the ARDS trials, that this is dangerous for the alveoli and the lung, and sets the patient up for that whole cascade of ventilator-induced lung injury. So if you're using a mode that is susceptible to that kind of double triggering, then the potential is there to injure the lung, and SIMV does that worse than some of the other modes do. And so a recent article, and that was one of the ones that I posted as pre-reading for this. I like the title on this. SIMV is a time to turn that workhorse out to pasture, and I wouldn't disagree with that. It doesn't seem to have. We know now that it doesn't have the same benefits in weaning patients like it used to have, and there are much better modes out there now in order to be able to do that. In fact, the spontaneous breathing trials are one of the primary ways to wean patients off ventilators now. So SIMV, even if it worked ideally the way we always thought it did, is still not as good as spontaneous breathing trials in that regard. So having said that, one of the things that I think that we need to consider as well too, that in the transport context, most of the patients that we're ventilating, we're not trying to wean them off the machine. So we're trying to supply for them complete control ventilation. So enough of a tidal volume and a respiratory rate and an FiO2 so that to meet their physiologic demands so they don't actually feel the need to breathe. Again, some of the research that's gone into the interaction between the diaphragm and the ventilator demonstrates that even when a patient is well sedated and that they will continue to have they will continue to have diaphragm function. So what I mean by that is that they may not visibly to us as the operators appear like the diaphragm is actually being triggered by neural impulses from the brain, but one investigator has discovered that when the lungs start to expand with a mechanical breath, that in itself can trigger the diaphragm to also have some electrical activity and contract. So it's not uncommon while you're ventilating patients, even if you sedate them well, that they will breathe along with the ventilator. And when I said earlier about patients that were breathing faster than the machine, so for example, if you set them up at 16 and they want 20, those people are not just breathing 4 additional breaths from what the ventilator is giving them, they're breathing 20 times per minute. So the first 16 breaths they're breathing along with the ventilator. And they may trigger those and they may not trigger them. It could be that they simply inhale right along with the machine's rate, but the additional 4 breaths, they are going to trigger those. And what I'm suggesting now in regards to this SIMV question is that those additional breaths should ideally be AC breaths. Now, the idea then once more is that if you're taking all the work of breathing away from an individual, and that's your desire, then an AC type of mode is the one that's going to do the best work for you, because those individuals will get the same consistent volume every single breath. Therefore, your cardiac output will be the same as well too. And you might say, well, we know that an increase in intrathoracic pressure is going to affect cardiac output. So if we have every single breath the same, but the important piece in that is that with every single breath the same, you can titrate your inotropes and chronotropes and fluid volume to get to a point of a cardiac output which is reasonable for what you're actually doing to this particular patient. In fact, quite a few years ago now, there was a chapter in the ICU book that was written about this particular piece around SIMV and assist control. And at that point in time, it was still accepted that people could use either one of the modes. And this individual said that one of the things that's important is that if somebody's had an acute MI and they have a very labile cardiac output, then ideally that person should have the same breaths on every single breath, and therefore the argument would support using AC on those patients, which in fact sounds counterintuitive, because if they've just had a cardiac event and it's affecting their cardiac output, AC is going to give you the highest intrathoracic pressure in comparison to a mode like SIMV. But he was specifically saying that it would be ideal to ventilate those patients on AC so every single breath is exactly the same and your cardiac output is consistent as well too. And then you'd have to use, like I said earlier, your pharmacotherapy and volume to ensure that your cardiac outputs are acceptable. So in looking through the medical directives, our recent ones that have been published within Ornge, you'll see in there that SIMV is not an option anymore when it comes to mechanical ventilation. The 2 options that you have, and I'm pleased to see the second one, the first one is assist control, and the second one is pressure support ventilation. And the nice thing about the pressure support ventilation piece is that if a patient has an intact respiratory drive, and assuming that it hasn't been sedated right out of them, or you haven't paralyzed them, then that respiratory drive, if it's an appropriate drive, will establish the right respiratory rate based on the tidal volume that you're giving the patient with the ventilator to manage their acid-base balance and their oxygenation. And so you're letting the patient cycle the machine, triggering every single breath. They're all pressure-supported breath, and you can titrate your pressure support levels to as high as you want to take most of the work away from the patient. or as little as we want so that they do some of the work. Recognizing again, as you well know, that we never use less than 8 centimeters of water pressure support, simply because that's about the resistance of an adult endotracheal tube. So if you decrease the pressure support to less than 8 when someone's breathing spontaneously through an endotracheal tube, then you're forcing them you're forcing more work upon them to take their tidal volume than it would be if you actually pulled the tube right out altogether. Okay. So I hope that answers the question on the SIMV piece. So really at this point, assist control and PSV are the ideal modes that we should be using. And partly because SIMV is, has been fingered as being more of a problem when it comes to dysynchrony with the patient, and the other piece is because it doesn't actually function the way we thought it did as far as offloading the muscles and giving the respiratory system a rest, or letting them work the respiratory system with some negative pressure in the chest. The other thing about this too is that when individuals talk about breath stacking when it comes to SIMV, they've talked about, well, there's smaller volumes with the spontaneous breath. Well, the thing is, if the patient's taking those spontaneous breaths and there is a real physiologic reason why they're doing that, so it's not because they're in pain or they're anxious, there's a physiological reason for that, then that tidal volume that they generate on that spontaneous breath should also be 6 to 8 mils per kilogram ideal body weight. So if your concern is that in assist control you're going to stack breaths because you're giving them the same volume on every single breath, if you're also setting up your pressure support on those spontaneous breaths with the same 6 to 8 mils per kilogram, then really 30 breaths per minute of AC at 6 to 8 mils per kilogram should look the same as 30 breaths per minute of 18 of them AC with 6 to 8 mils per kilogram, and the other 12 of a spontaneous breath with 6 to 8 mils per kilogram. The volumes are the same. Granted, the inspiratory times, etc., are going to be different in the flow rates, but nevertheless, there's the risk of breath stacking in that sense from a high respiratory rate with an inadequate expiratory volume exhalation. Either one could generate itself into an increase in functional residual capacity and the dynamic hyperinflation of the chest, which leads to all its own problems as well. So at the end of the day then, AC and pressure support. So I hope that answers that particular question anyways. And we did get into a bit of the dysynchrony piece at the same time too. Another question here deals with managing obese patients with ARDS, where the sending facility is reporting that they're using high levels of PEEP, high pressures, and large tidal volumes. Okay, interestingly enough, and I'm sure you're aware of this, and the reason that it comes to us and we understand this is that when we talk about ideal body weight, we calculate that based on the patient's height. So it's irregardless of the patient's weight, it's all based on the patient's height, because their thoracic cavity and their lung volume is going to be very similar to another person that's the same height as them, regardless of what the weight difference is between the two. So in this particular question, it talks about large tidal volumes. We don't need the large tidal volume, so that's the first piece about this that I wanted to talk about. The other part about it is the high levels of PEEP, and that's where we're going to get into this lung model, or the P. Richard lung model that I've got in front of you here, because the large mass of the patient's weight on their chest and in their abdomen as well can have some effect on their pleural pressures, which will affect how easy it is to expand the lungs. But if they have healthy lungs, and in this particular question is talking about ARDS, but let's take it back to someone who has healthy lungs. If you set your ventilator up correctly, it shouldn't take any more pressure to expand the healthy lung of a morbidly obese patient than it does for someone who's a regular size. The difference is that you'll need more PEEP, and to counterbalance that, the pressure that's on the lungs during the expiratory phase, which will have a tendency to try to collapse the chest. And so there's some interesting work that's going on around this sort of thing as well too, and it looks at how much pressure that actually required, because the thoracic cage is going to stabilize the lungs to a certain degree as well too, even from that excess weight. And but we know that the thoracic cage expands along with the diaphragm when we take a breath. So the point of this particular question then is that how do we ventilate these patients that are morbidly obese with ARDS, who we know have high pressures, to deliver tidal volumes and manage their oxygenation as well. The bottom line is that in our medical directives, again, we know that the limits for peak inspiratory pressure and plateau pressure are 30 centimeters of water. However, sometimes we have to exceed those limits based on a number of reasons. I think we all can appreciate that someone who's in acute asthmatic attack who has to be intubated and ventilated is going to require peak inspiratory pressures much higher than 30 centimeters of water, and we'll accept that because that's what's required. Similarly, if you need high pressures to get a reasonable tidal volume into somebody, then so be it. That's what you need. Now, having said that, we do go to a permissive hypercapnic strategy by dropping our tidal volumes from 6 to 8 mils per kilogram ideal weight to 4 to 6 mils per kilogram. And so when you drop it to 4 to 6, the smaller volume that you're delivering, it's going to take less pressure to deliver it. So it still may exceed 30, but it won't be as much pressure as required to deliver 6 to 8. So at the end of the day, we still have to ventilate our patients. And if it takes more pressure to do that, and we've optimized all our other parameters, then that's what it takes, is the more pressure. Just keep in mind as well too, we never go less than 4 mils per kilogram ideal body weight. And the reason for that is because we do have to have a dead space to tidal volume ratio which is acceptable, because if we get below that, an acceptable dead space to tidal volume ratio, then the CO2 will continue to climb and our patients are going to become extremely acidotic, and they won't survive that kind of ventilation. So we can't ventilate someone with less than 4 mils per kilogram ideal body weight. So I hope that answered that particular question. And the individual that sent that one in, if it didn't, then feel free to ask something on a different angle that might help me to understand where you're coming from on this. But there are going to be times when we do have to ventilate people with pressures that exceed that, and that's assuming, again, we've optimized everything else. Keep in mind as well too, when you get high pressures, and I'm not suggesting that this is the case with these obese individuals, and I'm making an assumption already when the question was asked that you've optimized some of these other things, that the first thing, first go-to is also always the dope pneumonic. So look for other reasons why the PIPs are high. And but if you've ruled out all those other things, so you suction out the tube, the patient's not chewing on the endotracheal tube, there isn't a pneumothorax, the tube isn't misplaced, and it's not an equipment failure, then you need to say, well, how can I effectively ventilate this patient and minimize the pressures that are required to do that? And once you get to that point, then you have to live with that. Okay. Moving along here to, and we're answering some of the other questions that, we're touching on some of the other parts which I would be dealing with a little bit later as well too. This individual said that they had a call for an 8-year-old child with severe physical deformities. They were 12 kilograms weight. They were in respiratory failure. So there were multiple ETT attempts that were unsuccessful, and eventually the patient received a tracheostomy with a number 3 uncuffed tube. They were difficult to ventilate due to the huge leak, and spent a long time with the staff at the sending facility adjusting flows, volumes, head position to achieve a consistent exhale volume. Other than having the trach switched for appropriate size, which wasn't an option in this particular case given what it took to get to where they are now, what suggestions would you say to optimize this child's ventilation? That's a good question. Leaks propose some really significant challenges for us, whether it's a small endotracheal tube that's uncuffed, or in a case like this, because of the physiology and the characteristics of the patient, you'd have to go to a small uncuffed airway, and now you need to ventilate and support this patient in that way. There are a few limitations with the LTV 1200, which is the ventilator that we use, and I understand there are some people online that may have other machines that they use as well. But within the Ornge system, the LTV is the machine that we have available for transport. And when you consider what actually happens when you're ventilating somebody who has a leak with a machine like the LTV 1200. So let's say that your patient is in pressure control, and when you consider what happens then in a pressure control breath is that the endotracheal tube is in place, and in this particular case it's a tracheostomy tube. So you have a ventilator circuit out here, and every time the ventilator cycles on, so let's say you're hitting a pressure of say 25 on 5. So 25 centimeters of water PIP and 25 centimeters of water PEEP. And when the ventilator cycles into inspiration, and let's say you've got it set up for, let's say 0.8 second inspiratory time, then the machine simply pressurizes its circuit to 25 centimeters of water. And at the beginning of inspiration, your airway is 5 centimeters of water. So the flow that's down the endotracheal tube is simply in response to a pressure gradient. And I appreciate that people understand this. I'm just trying to get to a point here. And that given enough time, most of that gas will actually escape out this way, depending on the size of the leak, and will not translate into a change in actual volume. We had a situation like this quite a few years ago in the neonatal unit where I worked in, and it was a difficult intubation, very similar to the story here without the tracheostomy. So it was just simply a smaller endotracheal tube that was put into the patient. And what the physician's argument was, when I disconnect the patient from the ventilator and I handbag them, that I can get the chest to rise with the same amount of volume or same amount of pressure as we're using with the ventilator. So that's my crude EVM. So what essentially he was saying was, because at that time in our NICU, we used to hook our resus bags up to a manometer, an electronic manometer. So this transducer was measuring pressure. So the pressures we generated with the bag were the same pressures that we were generating with the ventilator. And so the physician was saying, why when I generate pressures with the bag that are the same as the ventilator, I can get the chest to rise, but I can't get it to rise when I ventilate them with the ventilator. And the reasoning behind that is because when we're squeezing a bag, we can make subtle changes as with the strength that we squeeze the bag with that a ventilator can't do. And those subtle changes will help to stabilize this pressure and get the chest to actually rise. So there is a difference in that regard when it comes to how the tube, whether it's the ventilator or it's the bag that's actually generating those pressures. In addition to that, it's very difficult for us to have the same inspiratory time on a consistent basis when you're squeezing a bag. You may think that you are, but you may not. And the way that we typically ventilate neonates is it's just a quick puff. So it's not a slow squeeze of the bag. It's a quick puff. So the pressure is being generated quickly. So there are a couple of things that I'm saying here. One is that the bag can adjust itself to maintain pressures here and get the chest to rise. The ventilator can do something very similar as well too. So if this is the LTV and this is our ventilator circuit, if the pressure is escaping here because of a leak, the ventilator will just simply put more flow into the system because its goal is to maintain 25 centimeters of water pressure. And so so that particular piece about keeping the pressures consistent are very similar in regards to one over the other. But the thing is, with the bag, you can give a very rapid squirt of gas that before it gets a chance to turn the corner and escape, the lungs can actually expand, so you can generate more volume for the same given pressure. So at the end of the day, the response to this particular case could be an increase in PIP is what you might need. And it could also require, I was going to say an increase in inspiratory time, but I wouldn't necessarily go there. Or change your mode of ventilation from PC and change it to VC. And in that case, in the VC mode, if you decrease your inspiratory time, it accelerates the flow to deliver the same volume within that same period of I time. And as a result, that accelerated flow may achieve what you're trying to achieve as far as expanding the volume of the chest. Now, this is not something that I've had to do before because we didn't volume ventilate our neonates. But in consideration of what happens between a mechanical breath and a manual breath, this is one way to try to mimic what is going on between those two. So it could be another option that might get you to where you want to go in that particular situation. And if that fails, then the next piece might be manual ventilation. Now, within the context of Ornge, we're using those T-piece resuscitators now, which we're teaching in this year's CME. And those may get you where you want to go. However, again, you can't accelerate the flow in the same way with that TCP resuscitator, the T-piece resuscitator, as you can with a resus bag itself. So again, I trust that explained or gave a few options to the individual that asked that particular question. And I think at the end of the day, I believe that you manually ventilated this child, which may be the only option that's effectively gets the volumes in. But there are some strategies that you can use that I would try them first before I decided I was going to bag for the transport. Because one of the dangers of the resus bags, and that's why we have the T-piece system within the context of Ornge these days, is that the T-piece will actually give you consistent pressures, breath to breath to breath, where these pressures are inconsistent when you're bagging a patient. And even 2 or 3 centimeters of water one way or the other is going to change the tidal volume, especially if you're talking to tidal volumes of 50 or 60 mils per minute. or not mils per minute, but mils. And so in that regard, we want to be sure that with the T-piece resuscitator, we can give that some consistency in that. And that's just simply the limitations of transport ventilation when we have one single machine, which is very good in what it does, but when you get into some of these situations, it just doesn't have the ability to make changes. Okay. Some of you might be thinking, though, well, if I want to accelerate the flow on inspiration, couldn't I just decrease the rise time? And you can do that on the LTV. So you could go into the background menus and increase how quickly the ventilator achieves its peak inspiratory pressure. And you can see whether that gives you some benefit as well, too. Keeping in mind, that's only functional in the pressure control mode. It's not operational on a volume control breath. Okay. That's
so
Sean, there's a question.
Email question, and I think you alluded to it partly, but question from Matt Coulombe. When venting a small infant, 6.5 kilograms is what he gives as an example, with the LTV, there's a lot of dead space. How do you deal with that?
Okay, good question. I can see actually that this presentation may turn more into a question and answer thing, but it's going to address some of our other pieces as well, and if some of the questions don't get there, I'll make sure that we cover those things near the end. So can you just tell me a bit more about that question once more, please, Sean?
So he asked specifically, so if you have a 6.5 kilogram child, a small infant, and you're using the LTV, there's a lot of dead space.
Yeah, okay, good. Okay, I'm going to back up just a bit to get to that question. One of the things to keep in mind is that when you intubate an individual, and assuming that it's a cuff tube, now in our cases this would be an uncuffed tube, but an uncuffed tube makes actually this even a little bit easier. But the school of thought and what people have accepted is that if you put an appropriate size endotracheal tube into your patient, then you decrease the anatomical dead space by 50%. And when you attach your ventilator, we have a number of bits of hardware that we attach on there as well. So there is our adapter for our end-tidal CO2. There's also our heat moisture exchanger, and then there's also our inline suction catheters. So every single one of these pieces increase the mechanical dead space. And the thing is that if you use the appropriate size piece for your patient, then the volume that you add here will pretty much make up for what you lost when you intubated the patient. So the 50% less of your anatomical dead space, you're typically giving it back to the patient with mechanical dead space if you're using the right bits of equipment. And now, having said that, we sometimes use a number of different strategies to try to ventilate these smaller kids more effectively. So you can eliminate some of this mechanical dead space. Now, what you choose to eliminate depends on what you think is most important. So the end-tidal CO2 piece, the HME, or the inline suction catheter. And every time you eliminate one of these, you're decreasing the anatomical dead space. I would argue that the end-tidal CO2 is important. Actually, I would argue all these are important, but if I had my choice, I would take this one out first. I know that we also take out the HME, but quite frankly, if you've ever had surgery and you've been ventilated for anything more than 30 minutes or 60 minutes, and you don't have an HME in place, you can feel how uncomfortable your chest is after that period of time breathing dry, cold gas. But nevertheless, if you can't ventilate effectively with that in place, then taking it out can give you more ventilation or more effective ventilation. The other thing, too, is that if you have, because you have an uncuffed tube, because you have an uncuffed tube, the leak in an appropriate sized endotracheal tube in a child that size typically doesn't occur until the end of inspiration. So the pressure is rising in the chest, and it dilates the airways, and eventually it dilates the trachea enough that some of this gas squirts out here. So you don't necessarily hear a leak through the whole inspiratory phase, and nor do you necessarily hear a leak during the expiratory phase. And so as a result, as some of that gas escapes, once you get to expiration, it could be just as It could be just as if the tube was cuffed because there may not be a leak. But if there is a leak, and that's why I was going to this place, that if there is a leak during the expiratory phase, then what happens is that you actually have a pressure gradient from the mouth down here to the distal tip of the endotracheal tube. And so during that expiratory phase, there's also gas going down that endotracheal tube trying to stabilize, let's say that you have them on a PEEP of 5, trying to ensure that your system up here stays at a PEEP of 5, but as gas is flowing down here, that pressure would drop if it wasn't for the fact that the machine puts more flow in to make sure that this stabilizes at whatever PEEP setting that you've set things at. So what happens is that this flow going down your endotracheal tube during the expiratory phase comes out the distal end, leaks out past the mouth, and what does it do to the alveolar gas that's inside the endotracheal tube? It actually washes it out. So in effect, that constant flow of gas going through here with a leak that's continuous during the expiratory phase. I can't say that enough. That's the important piece in this. If there's a leak continuous during the expiratory phase, then this is no longer dead space anymore, because you're actually, and technically it is, but you're flushing out that dead space gas during the expiratory phase because of the leak. And I think that probably the best way to understand this completely is to look at this particular model or diagram. So if you have an individual, you have Homer Simpson here, and you have an end-tidal CO2 monitor out here, and you're sampling gas from the mouth through your end-tidal CO2 monitor. When this patient begins exhalation, the first bit of gas that is sampled by your end-tidal CO2 monitor is dead space gas. So the dead space of his oral cavity, the dead space of his trachea. So if you were to expand the end-tidal CO2 waveform, you would see at the very beginning of expiration, you would see 0 carbon dioxide in the exhaled gas, even though the patient's actually exhaling, because there's no gas exchange that took place in these upper airways, so there's no carbon dioxide there. That's essentially ambient gas. Eventually, as exhalation continues, you get alveolar gas coming out of the mouth. So on our end-tidal CO2 waveform, we see the CO2 level rise very quickly and then plateau out for the rest of inspiration. And when it plateaus out, that means that that's only alveolar gas that you have coming out during that plateau phase. And because alveoli empty at different rates, you still may have a bit of an increase in this during this plateau phase, and that's why these things are called end-tidal CO2, because it's the highest carbon dioxide level that it sees at the end-tidal breath, which is the end of the waveform here. The thing that happens then is on inspiration, the CO2 rapidly drops back down to 0 again, and what we have, though, as inspiration begins, we have essentially alveolar gas inside our airways. So the alveolus had CO2 that it exhaled on the previous breath. So at the end of exhalation, this is alveolar gas inside our conducting airways. So that when the patient inhales, at the beginning of the next inspiration, the gas that goes back to the alveolus is the gas it tried to get rid of on the last breath. So the first bit of gas that gets back to the alveolus is equal to the CO2 that it tried to get rid of on the previous breath. And as you continue to inhale your tidal volume, then what happens, eventually you get fresh gas down to this alveolar unit that dilutes the CO2 in the alveolus, so that CO2 that's coming through from the venous side of the pulmonary circulation can diffuse into the alveolus and gets exhaled on the next breath. And that's the important piece, is the size of this tidal volume. And typically it should be 3 times the size of the dead space volume. So what that simply means is that our anatomical dead space is a constant volume. It changes as we get larger, but it's constant. It doesn't change rapidly from breath to breath. What does change is our tidal volume, and as long as our tidal volume is 3 times the size of our dead space volume, we're going to control CO2 effectively. Now, we can actually control up to 50% dead space to tidal volume ratio, but we will be uncomfortable. So if our tidal volume got smaller, which happens if we become tachypnic and our respiratory rates hit 30, 40 breaths per minute, our tidal volume gets smaller, but our dead space volume doesn't. Sorry, that's dead space volume there. So our tidal volume gets smaller, but our dead space volume stays the same. And so then our ratio increases. And as a result, the CO2 levels start to rise. And we'll feel that, but if you're reasonably healthy, you can manage a 50% dead space to tidal volume ratio. Anything more than that, then you need to be mechanically supported. So to get back to the question that was asked with regards to the small tidal volume, or the small patient with small tidal volumes, and taking away some of this mechanical dead space up here, it's a reasonable thing to do, because what it does is it actually decreases this dead space to tidal volume ratio. So without having to increase your tidal volume, you're decreasing the mechanical dead space, decreasing the ratio, so you get more effective alveolar ventilation as a result of that. So bottom line, it's a reasonable option, but ensure that you're doing everything else that you can do first, because ideally those bits and pieces that you use that create mechanical dead space have a purpose. So the main point is that use the right size for the patient that you have, and in those smaller kids, it's not unreasonable to take away some of that dead space if that's what you need. So I've got a couple more questions here that, again, will relate to some of the things we're talking about. I've got a question here about the recruitment maneuver. And in our medical directives, we have a recruitment maneuver, which it's called a 20-20 maneuver. And for those of you that aren't familiar with the Ornge medical directives, the 20-20 maneuver is simply we set a patient up for 2 to 3 minutes on the LTV with 20 centimeters of water pressure control, 20 centimeters of water PEEP, and an IU ratio of 4 to 1. So 20 and 20, and an IU ratio of 4 to 1. And the respiratory rate then is set by whatever the patient required at the time when you started the maneuver. So if you're ventilating at a certain rate, at 20 or 30 breaths per minute, and this is for the ARDS patient again, remember, because not every hypoxemic patient needs a recruit maneuver, because not all of them are hypoxemic because they have consolidated lung. And so it needs to be a patient who actually has a diagnosis of ARDS, and that pathology is when we would use this maneuver. And just to go through this quickly again, for those of you that may not be familiar with it, the point of this particular maneuver is because the LTV 1200 cannot do the 40-40 maneuver, which is the one that the literature talks about the most, which is holding the lung for 40, it's not neat, but holding the lung for 40 seconds at 40 centimeters of water pressure. And the idea behind that is if you give the lung enough time exposed to this kind of pressure, you're going to recruit alveolar units. We can't do that with the LTV, partly because the LTV has a maximum PEEP of 20 centimeters of water, and this is essentially a CPAP of 40 centimeters of water when you perform a 40 maneuver. And the LTV can't do that because it just doesn't have the ability to generate pressures that high. This particular maneuver is also one that's discussed in the literature. However, they're using pressures that are even higher than 20 and 20. So the question I had was, this particular maneuver, what are the chances of generating a pneumothorax and making things worse for the patient? The literature talks about the fact that recruitment maneuvers, one of the risks are pneumothoraces. There are other risks as well too, such as volutrauma that doesn't necessarily mean a pneumothorax. It does have an effect on your cardiac output as well too, and your patients have to be reasonably well sedated, because think about this, for 40 seconds at 40 centimeters of water, you don't want any spontaneous, or you don't necessarily want spontaneous breaths in there. That would be uncomfortable for a patient. And if you have someone with ARDS who's at a point where a recruit maneuver is necessary, then this particular patient probably will be sedated to apnea or actually may have pharmacological paralysis at this point as well. So they'll tolerate this when you do these maneuvers. So this particular maneuver, though, cycles back and forth between 20 centimeters of PEEP and 40 centimeters of PIP, with a difference between the two of 20 centimeters of water with an IU ratio of 4 to 1. And interestingly enough, if you choose to do that with the ventilator that you have, try this out with a test lung sometime. And the important thing is the mean airway pressure that actually creates. And with that kind of maneuver, your mean airway pressure, it doesn't matter what your respiratory rate is, will be somewhere between 35 and 30 centimeters of water. And that's essentially that's the piece that does most of the recruitment, because that's the pressure the lung is going to be exposed at to most of the time. There will be alveoli that open when there's an inspiratory breath. However, this is the pressure, and therefore also the volume that the lung will be exposed at most of the time during that 2 to 3 minute period. And so going back to the question about, what's the risk of a pneumothorax? The literature that I found doesn't necessarily talk about recruit maneuvers increasing the rate of pneumothorax, but pneumothoraces are certainly a problem with people who have ARDS. And one of the articles I was looking at suggested that, or made the claim that pneumothoraces in ARDS will show up about, I believe it says 10% of the time you will get a pneumothorax. Oh, here it is, yeah. 8 to 10% of patients with ARDS will develop a pneumothorax. The scary piece about that is if they do get a pneumothorax as a result, and they have ARDS, 50% of those, the mortality rate is 50% for those individuals. So you definitely want to avoid pneumothoraces, and I know that we want to avoid them anytime. But in this particular population, there's even more of a reason to avoid them. And the question then is, will a recruit maneuver increase the risk of a pneumothorax? I guess the question needs to be asked then is that if the patient can tolerate the hypoxemia they have that would lead you to maybe considering a recruit maneuver, then go with what you've got with the hypoxemia, like in a permissive hypoxemia state. However, if you feel that a recruit maneuver is necessary to ventilate them effectively, then it counterbalances what might be the risk of a pneumothorax at this time. Keeping in mind as well too that not everybody is going to benefit from recruit maneuvers, and there is some evidence that's being published now that demonstrates that they may not be the be-all and end-all that we thought, and maybe they're not the thing that we should be doing all the time. But within the context of Ornge, we're still advocating these, and people are still doing them in critical care units as well too, recognizing that they're not going to help everybody with ARDS. So if the ARDS is if you catch it within 24 to 36 hours, that's when the recruit maneuver is going to give you the most benefit. And similarly, if the ARDS is a result of something external to the lungs, so if there's an abscess in the belly that's resulted in ARDS, or any of the other things which have caused the ARDS, then those lungs are more open. Yeah, open is a good word. Those lungs are more open to a recruit maneuver that they will have some benefit than if the ARDS originated in the lung to begin with. So a couple of things to consider. If the person needs an RM, then go ahead and do it. If they didn't respond to it, it may not necessarily be, it may be that they're just not one of those responders. And it could be someone who's outside that window that I just talked about who are the ideal candidates for it. So I hope that answers that particular question. And again, the individual that sent that in, if you want to add something to it, then definitely you can write in, and we can talk about that a bit more if you like. But that's so essentially this particular maneuver is one that's performed in the literature with pressures higher than we use in Ornge, and used effectively. In fact, it's been about 1.5 years now since it's been part of our strategies within Ornge and using it with the LTV. And it was a few weeks after we performed the CME that one of the individuals in the north said, we just had a patient who we performed a recruit maneuver, and it was amazing because it actually worked, and they had an increase in saturation as a result. Now the interesting thing is the evidence around ARDS demonstrates that an increase in saturation does not necessarily mean that everything's good now as far as this patient is concerned. And within the context of transport, where we see people for a brief period of times, we might perform a recruit maneuver, get an increase in saturation, hand the patient off at the receiving end, and still have a good saturation. However, the recruit maneuver actually did some harm, which resulted in the patient further down the road exhibiting some more lung disease and lung damage, which results in them doing that much worse. And so the important thing with recruit maneuvers is that you give them an adequate enough PEEP after the maneuver. And in the research that's been performed on animals, and this goes back a number of years now already, but what was discovered was when you perform a recruit maneuver, it's easy for you to, I shouldn't say easy, but the goal is to recruit lung unit which was consolidated or lung unit that was participating in that repetitive collapse and expansion from expiration to insulation. And we know that those are the lung units which are most susceptible to damage. And if we can recruit them and stabilize them so they don't collapse anymore between inspiration and expiration, then we've actually gained something as far as the individuals are concerned. And what this investigator discovered in his research was that if you perform a recruit maneuver without adequate PEEP following the maneuver, you actually have more lung which is opening and closing between inspiration and expiration than you had pre-recruit maneuver. And the significance of that is that that may result in an increase in oxygenation for a brief period of time, but you have more lung injury that results in a more severe ARDS. And so with our particular recruit maneuver, once you perform the maneuver, we increase the PEEP by 2 above what it was prior to the maneuver itself. So you've performed the maneuver, increase the PEEP, and see whether that sustains the gain in oxygenation that you achieved with the maneuver, if indeed there was one. And if your SATs deteriorate at that point, you can repeat the maneuver as well. So just to wrap this up, the 40-40 maneuver is the one that's probably been researched the most. So at the sending facility, if they're on a ventilator and there are staff there that are comfortable with performing this maneuver, then perform that one. Clamp your endotracheal tube and make the transfer over to your the LTV. If you can't perform this one for whatever the reason might be, then this is the reasonable option in that case. Okay. The one difficulty of standing here looking at a camera is that you don't see the reaction on people's faces. So I don't see whether people are rolling their eyes going, Mike, really? Or if they're going, yeah, awesome, that's exactly what I wanted to hear. So let me see here. I got a couple other questions. And let's see. See, I think that we covered most of those. And
I have one more question.
Yeah. Okay. Yeah.
So Ben White asked, when ventilating patients with neural issues, for example, a head injury, he says they normally breathe without stimulation of carbon dioxide buildup. What is the best strategy for ventilating this head injury patient, and what is the threshold for paralysis? So I did mention that we're going to do a future webinar on the whole concept of paralysis and pain management.
Yes.
But maybe talk about the head injury.
Yeah, okay, the head injury patients are going to be challenging ones. If they have erratic respiratory patterns like Shane Stokes respiration, then that's really difficult to ventilate those patients, because you set them up on AC because there's an apneic period there, so they're not a candidate for pressure support ventilation. And then they do this aggressive inspiration, take these large inspiratory breaths, and then they can progressively get smaller, and then they're apneic again. And really, you just have to ventilate around those. They'll trigger the ventilator during those periods of time. The tidal volumes are going to be excessive. There's no way really to limit those unless you suppress those ventilations altogether. And I appreciate the fact that the neurologists at the receiving end of a patient who has a head injury do not want these patients paralyzed, because then they cannot perform an assessment. So if you're stuck in that kind of a situation, you just have to allow them to do their own respiratory patterns and then ventilate them effectively in between. So during the apneic period, give them an appropriate tidal volume, and that should reasonably manage your carbon dioxide levels. And they're going to do, things are going to change dramatically when they start their own respiratory pattern. But during the apneic phase, and I'm only talking again of Shane Stokes respirations, and there are different patterns that a head injury patient can exhibit. And if you absolutely cannot ventilate them effectively because of the pattern that they're using, then I would suggest that it's like they're not going to survive if you don't ventilate them. And if the only option is to paralyze them so you can ventilate them, or sedate them down to apnea, then I can't see you having any other options but to do that. This particular thing, though, brings up something else as well too, which and I'm glad that this question was asked, because it leads to another question that I've received a number of times over the time that I've spent with Ornge as an employee, and that is that when you have patients with a traumatic brain injury, that there are times in these individuals where you'll get a low PEEP alarm, and the individuals were saying, that the patients doesn't appear to be ventilating ineffectively. They just simply have this low PEEP alarm that goes off on a regular basis. So you silence the alarm, 2 minutes later the alarm starts ringing again. And it's not just in the brain injured patients, it can happen in other patients as well too. And the way to understand why this is happening is to understand what is it that actually triggers a low PEEP alarm. And what the PEEP threshold, or the low PEEP alarm threshold, is 3 centimeters of water pressure less than your set PEEP. And this is, we're talking about the LTB again here in this. So what that simply means is whatever you set your PEEP level at, 3 centimeters of water less than that threshold is when a low PEEP alarm is going to be triggered. So the next question is then what sort of things will allow the pressure to drop this low? And if you were to look at a pressure waveform, if you had these actually available to you. So let's say that your PEEP is set at 5 and they're on pressure control of 20. And let's say the patient's on a respiratory rate of 16 breaths per minute. And they're breathing along with you at 16 breaths per minute. So it is possible that when the patient triggers the ventilator, that their inspiratory effort is great enough that the LTV doesn't respond quick enough to spool up its turbine to get the flow into the system to make up the flow that the patient wants. So in another word is that if the patient's inspiratory effort exceeds the flow that's in the ventilator circuit, the pressure is going to drop. It has no choice. It has to drop. And if it drops to less than 2 centimeters of water, which exceeds this threshold, you will get a low PEEP alarm. And the reason why I started this in talking about the head injured patient, which is where the question came from as well too, was the fact that because I had a question exactly like this for a patient that had Cheyne-Stokes, that was exhibiting Cheyne-Stokes respiration. During the apneic period, things worked fine. When the patient began their aggressive inspiratory efforts at the beginning of that respiratory pattern, that's characteristics of Cheyne-Stokes, that's when they exceeded the flow of the ventilator and the low PEEP alarm was triggered. So as their tidal volumes and their effort deteriorates, then they're no longer triggering the alarm at that point. But the next time they start that whole cycle, then they go right through that, back to that same thing once more. And the one way around this is because this is typically a nuisance alarm. And there was an alert that was sent out from the ministry quite a few years ago now, and it was directed at critical care hospitals, and was looking at or was addressing the fact that specifically in post-anesthetic care units, where individuals were turning down the alarm thresholds on their heart monitors to avoid nuisance alarms. And there was an adverse event as a result of that in a particular hospital, and that's why this report came out and said, that we should not be adjusting alarms to eliminate nuisance alarms. And I'll tell you why this relates to what what I started telling you earlier, so that this all makes sense as to why I'm going here. And the point of it was that there were a number of events where alarms should have been triggered that weren't triggered, and patients had an adverse event as a result, because patients that have in a post-anesthetic care unit, their chemoreceptors to hypoxemia are blunted, and as a result, they can have a hypoxemic event, but they don't increase their alveolar ventilation the way you or I would if we had the same sort of thing happening. And so you can see that if a heart rate monitor or blood pressure, etc., was decreased as far as its alarm limits were concerned, and so alarm was not triggered, then you could have an adverse event which would be detrimental to the patient. And so, having said that, that was my sidebar, because I'm telling you now that you can actually change this alarm limit for your low PEEP. And I'm comfortable in people doing that because the typical reasons for a low PEEP alarm would be associated more with a disconnect. And in that particular case, if you were ventilator disconnected from the patient, then you would get other alarms in addition to just simply a low PEEP alarm. So by eliminating the low PEEP alarm, you're not adversely affecting the safety of your patient, because there are no other alarms that'll go off, because there are other alarms that'll go off. But the point where I'm getting at is this, that in the background menu on the machine in the alarm section, and when you go to low PEEP, you can adjust this PEEP threshold of 3 centimeters of water anywhere from 1 all the way down to 20, or you can eliminate it altogether. And what it simply does is that if you were to drop this down to 10, what it's simply telling you that the patient that's breathing like this, that exceeds the threshold of 3 centimeters of water and triggers that alarm, may not do that at 10, and most people won't do that on 20. And if you turn it off altogether, then it's never going to happen on that particular patient. The interesting thing to keep in mind is that if you turn off the machine and you turn it back on again and you select a new patient, then the machine defaults all the way back to this 3 again. So changing things in the background for one particular patient is not going to save it for the next patient unless you pick the same patient, which I hope you're not doing because we're not always the same patient. So that's an option for you on that particular case. So I think I got off on a tangent a bit from what the question was originally, but I hope that somewhere in all of that it answered the question as well too. And I think I started out by saying that some of those patterns, if you don't paralyze them or sedate them to apnea, you just have to ventilate along with them. And as long as your end-tidal CO2s are reasonable, I mean, they may drop quite low during the aggressive period and then they'll come back up again, which also has something that I should say about as well too, because if many of you, if you were around about 4 years ago, Dr. Jeff Singh gave a voiced-over PowerPoint presentation on traumatic brain injury patients and how to manage them safely. And there's one thing that he said in that really stuck out in my mind because I thought it was so dramatic. He said that for each millimeter of mercury change in end-tidal CO2, there's a 2% change in blood volume in the head, which is quite remarkable because we might think that a 5 millimeter of mercury change in CO2 or a 10 millimeter may not be that dramatic and we'll bring them back down again by managing our machine. But 10 millimeters of mercury change is a 20% change in blood volume in the head, which seems considerable when you're thinking about someone with a head injury and you're talking about pressure. So, and that goes both ways. So that's a 20% decrease in volume if your end-tidal CO2 dropped by 10, or a 20% increase, excuse me, if your end-tidal CO2 increased by 10. So just something to keep in mind in that regard. Okay. Good. So I think that answered most of the questions, and and in addition to that, it addressed some of the things that I wanted to cover today. But I've got a bit of time here, about another 30 minutes, and I want to talk about patient-ventilator interaction. And the literature demonstrates that dyssynchrony between the patient and your ventilator happens on a regular basis. And if we go back to what the ideal respiratory or the ideal ventilator breath would look like, it would be one that would trigger as soon as the diaphragm starts to contract. It would deliver flows in with subtle changes based on how the patient's inhaling during the inspiratory phase, and it would cycle off into expiration at the time that the patient wants it. And when you think about that, then we can relate it to what our LTV is capable of doing, and we can hopefully appreciate why we do have asynchrony. And in a ventilator like the LTV, it actually might be a little bit higher based on the type of patients we transport, but in the transport context, typically we're trying to get the patients from a sending facility to a receiving facility safely and ventilated effectively, which requires a certain amount of sedation and analgesics and sometimes paralysis, which allows us to ventilate them in the way that, that we choose to without a lot of input from the patient. Now, having said that, occasionally we will have input from the patients. And when I started the session out, I talked about, for the brief period of time that we have patients, are there things that we do in transport that can affect the patient down the road? And one of them is what we use for analgesics and sedation. So if we overuse sedation, it's similar, actually the context is the same as if it was overused in the emerge department, and what that leads to in the way of ICU effects as far as the individual having psychoses, or ICU psychoses, which is a term that's sometimes used, that can come about when sedatives are overused instead of analgesics. So I'm not going to get into that because that gets out of my particular realm of expertise. And as Sean said earlier, we're going to set up a CME that's dealing specifically with sedation of ventilated or transported patients, which will address some of those things. So I'm not going to go in that particular direction. But when we ventilate our patients, it's important for us to appreciate what can cause asynchrony. So when we talk about the LTV uses a flow trigger to get the breath started. And keep in mind that in order for flow to be generated, so if the ventilator is triggering off a flow from the patient, then before the machine knows that the patient wants a breath, they've already started the breath. So the diaphragm's already contracting, and the ventilator still is not showing any pressure. So if this is pressure here, and let's say we've got a PEEP of 5 and a PIP of 20, for argument's sake, the patient's actually already inhaling, the diaphragm's contracting before the ventilator actually recognizes the breath, because the LTV is flow triggered, and we all understand that and see that on the ventilator, and people manipulate that effectively across the province based on the conversations I've had with them. But just very quickly to recognize what that actually means is that the sensors that come off distal to the Y of the ventilator circuit connector measure 2 pressures. So there's a P1 and a P2. And when a patient inhales, flow is going past these 2 sensors. And so simply because of the way flow is created, where it is generated from a high pressure to a low pressure, P1 has to be greater than P2 if we're in inspiration. And that pressure signal then is translated into flow, and the default in the adult mode on the ventilator is 3 liters per minute. So when the patient begins to exhale, there needs to be 3 liters per minute going past these 2 flow sensors, and at that point the machine recognizes inspiration and it kicks into a breath. So if they're in assist control, it'll be assist control breath. If they're in pressure support ventilation, it'll be a PSV breath. But regardless of what it is, whether it's volume or controlled breath, that's how the breath gets triggered. But keeping in mind, the patient's already a little way down the road in their inspiration before the ventilator actually recognizes it. So the next thing then is how does the flow change during this inspiratory portion here? So in a volume controlled breath, all of you have seen when you're operating the LTV, it'll show you a flow calculated flow, it calls it. And what that simply means is that given the inspiratory time that you've set, the machine says that within this inspiratory time, I will deliver the volume that you set. And the last few milliliters of that volume will enter the patient at the very end of that inspiratory time. So, for example, if you set this patient up for a 1 second inspiratory time, and they have a tidal volume of 500 cc's, and we're talking again in volume control, the last bit of that 500 cc's will be delivered at the end of that 1 second. And that's how the machine calculates the flow for you. It gives you a calculated flow. It simply says that based on your I time and your tidal volume, this is how much flow it'll take to get that volume in that period of time. And we can't change that. Or we can only change that flow by changing our I time or changing our volume. Whereas other ventilators which cost more and are, so I was going to use the word sophisticated. I don't want you to think that the LTV is a dinosaur. That's not my point at all in saying this. It's an extremely robust ventilator and does a great job for almost everything that we need, but there are some limitations to it, and this is one of them. Most ventilators on the market can disassociate volume and flow and time, so you can adjust those parameters independent of each other, and make some, and therefore you can titrate a few things for your patient. But we started out by talking about the trigger for ventilation, and this is part of where the dyssynchrony actually occurs, is the patient starts to inhale before and there's a bit of time before the ventilator catches up. Now, the flow in volume control during the inspiratory phase, the machine can't do anything about that. So even if the patient sucks more on the ventilator to get more flow, the ventilator can't change that flow when you're in volume control. It simply says, I'm delivering this volume, and that's the flow rate that you're going to get with it. What happens is that you'll just have a lower PIP. So if your patient's breathing aggressively, or actually even if they're breathing comfortably along with a volume control type ventilation, it's going to affect your peak inspiratory pressure. And this is why sometimes if you bolus a patient with sedation, that occasionally your peak inspiratory pressure periodically, for a brief period of time, increases even though you're in volume control. It increases simply because the patient's not making those inspiratory efforts anymore, and or not as aggressive as they were before. And once that initial higher dose of sedative wears off, then things all return to where they were normal. The other piece then is that if they're in PC, your tidal volume drops off at the point where you've given them that bolus of sedation. And it will come back again as they start breathing a little more aggressively than they were before. Their participation in ventilation depends on how aggressive their inspiration is. So if it's aggressive enough to trigger the flow trigger, then they'll trigger the rate. But even if your patients are not triggering the breath, so you're not seeing patient effort-like flash, it doesn't mean that they're not inhaling along with the breath. They still could be inhaling along with it as well too, but it could be triggered, as I was saying earlier, by simply, as the lungs expand and they start to push the diaphragm down, then there's a secondary trigger of the respiratory muscles of the diaphragm, which affects it as well. So that, and in that case, it's not they're not participating a lot in ventilation, but they are inhaling along with the ventilator as well too. The next point that's important here then is, we're talking about inspiratory flow. If they're in pressure control, we don't have direct control over the flow rate in pressure control, even though the ventilator, if you change the I time, you've probably noticed that the flow calculation changes in the display, even though you're in pressure control when you're changing the I time. And it's simply because it's one of the idiosyncrasies of the LTV 1200 is that when you change the I time, it's simply resetting the calculated flow based on the tidal volume should you change to the tidal volume mode. But the calculated flow has nothing to do with your pressure control breath, because the flow down an endotracheal tube is all about the pressure at the mouth and the pressure here in the trachea, or in your large airways. So if it's 20 up here during inspiration and 5 down here, the flow down your endotracheal tube is in response to that pressure gradient. And as the pressure gradient gets less, then your flow tapers off as well too. And then this leads us to the next part of our pressure waveform, which is the expiratory portion of it. Because in a PSV breath, the default for the LTV is what's called a 25% flow termination. And the reason why I'm bringing this up is because it relates to patient-ventilator synchrony. What this termination simply does is that the ventilator knows what the flow was at the beginning of inspiration, or during the inspiratory phase. And so let's say this flow was 80 liters per minute. And what the ventilator says that when the flow deteriorates, because as the lungs expand, the flow rate down through the airways gets less, which is measured at your flow sensors here, or your pressure sensors in your ventilator circuit. And once these sensors sense the pressure, or the flow, deteriorates to 25% of the peak flow of that particular breath, the ventilator drops the pressure support to whatever your level of PEEP is. And the result of that is that the patient has a bit more inspiratory time left, but they're not going to have this high peak inspiratory pressure when they go to exhale. So simply what it does is it ensures that that higher pressure is gone when the patient wants to exhale, so that they don't have to exhale against that and create some discomfort as far as the patient is concerned. And that's what the 25% flow termination is. So when it comes to the LTV, a pressure-supported breath is probably the way that the machine can best tailor itself to what the patient's needs are. So the respiratory rate is set by the patient. They trigger the ventilator, which is associated obviously with the respiratory rate. Because we're in pressure support breaths, they can tailor the flow that's being generated in this portion as well too, because the machine's goal is to make sure that the pressure in the circuit is equal to your pressure supported breath. So let's say your pressure is 20. If the patient becomes more aggressive in inspiration, then the machine just puts more flow in the circuit to make sure that the pressure in the circuit stays at 20 centimeters of water. So the patient has the ability to vary the flow based on what their demands are. And then there's the 25% cycle time, which means that, or 25% flow cycle, so that the inspiratory time is also determined by the patient. So pressure-supported breaths work quite nicely in conjunction with what the patient wants. Now, people will argue that, well, the LTV doesn't have the latest in technology as far as sensing breaths and sensing flow, et cetera, so there's machines that will do that more effectively, and I agree. So, but as far as the LTV is concerned, given what the machine can do, a PSV is probably the method which will tailor itself the best to your patient. I think we should also talk about the AC piece though, because this actually can create some other problems for you. So if your patient is breathing, and that's why PSV breathing will work nicely for patients, and that's why I'm pleased that it's part of your part of your strategy for ventilated patients with an intact respiratory drive. Because if you're in AC and if someone has an intact respiratory drive, and I'm not suggesting you can't ventilate them, but in AC there's a couple of things which create some problems. So in AC, if we compare the patient and the ventilator, the patient can trigger the machine, or time can trigger the machine. Once the breath is actually triggered, the patient has no control. They can actually affect the flow they're receiving to some degree. So if they increase their inspiratory effort, just like in PSV, the machine's goal is to maintain the pressure that you set in the circuit. So if you set it to be 20 and the patient becomes extremely aggressive at this end, the machine just puts more flow in here to make sure that it stays at 20 during the inspiratory phase. So there is some flexibility with flow. However, the machine itself will not change the flow. All the machine cares about is generating pressure in the circuit. This again is in a PC breath. We'll talk about volume in just a second. When it comes to cycling off, the patient has no control in a pressure-controlled volume breath to prematurely cycle the inspiratory phase. So cycling to expiration is also time as far as the ventilator is concerned. And so you can see where we can set this patient up for some discomfort and some asynchrony. The trigger piece is the same as any other trigger. The flow piece, well, they have some control if they're in PC, but they have no control at all over the I time. So if they want to exhale before the I time is up, they can't. And if they want to exhale after the I time is up, if they want to inhale longer than the I time that the ventilator is set for, the machine's not going to let them do that either. And you can see what can happen in this, because when you look at the asynchrony literature, it talks about a number of different things that can happen. So you can have a late trigger, you can have no trigger, you can have double triggering happening, and each one of those things is uncomfortable for the patient. It can result in hypercapnia, it can result in more anxiety on the patient's case. It can result in more barotrauma as well too, and at the end of the day, none of those things are good for the patient, and are uncomfortable for them as well too. So there is a way to try to tailor a pressure control breath more to what the patient wants. So, and some of you may actually be familiar with this. In the background menu, you can turn something on which is called pressure control termination. And the default position of the ventilator when you turn it on is that this feature is off. However, you can go into the background menu and activate it and turn it on. And what it does then is that it takes the characteristics of flow termination and now applies it to a pressure control breath. So if you haven't adjusted your 25% flow termination for a PSV breath, the machine will take that 25% and apply it to your pressure control breath. And now your pressure control breath will behave exactly as what I drew up here. Now this is a bit cluttered up here, but again, the definition is that once the flow within this pressure controlled inspiratory breath deteriorates to 25% of what the peak flow was in that breath, then the machine cycles to expiration. So it drops the pressure down to your level of PEEP, and if the patient's still inhaling, and they will be for a brief period of time, the machine will allow them to finish their inspiration without having that pressure there. So the one benefit of that is that it can help in the patient who has an inspiratory time, which is a spontaneous inspiratory time, which is less than the I time of the ventilator. And so you're going to take away some of this discomfort. The problem comes into play where the I time spontaneous is greater than the I time of the vent. And here the machine really can't do anything about that at all. And in fact, if you try this with yourself, the machine will do one of two things. It will ignore it completely, which means that gives the patient a breath, they're still inhaling, but there's no additional flow there, and inspiration is over. Like when I say there's no additional flow, there's still the 10 liters per minute of bias flow, plus the fact that the machine, if your PEEP is set at 5 and the patient's inhaling, then they're going to be taking some of that 5 pressure away from expiration. So let me just back up again. So in the expiratory phase, if your PEEP is set at 5 and your patient's inhaling longer than inspiration on the ventilator was set, then the machine will just simply put more flow in here again to keep this pressure at 5. That's one way it might react. The other way is that once you exceed the mandatory expiratory time, and it's not very, and I think it's 375 milliseconds. So what that simply means is that the way the LTV is designed is that you can never have less than 375 milliseconds between a breath, which seems quite short, and it is. But what it simply says is that it'll always allow some time to get that air out. Whether you get all of it out, the machine doesn't really, it can't tell. But it simply says that even if you're inhaling past the inspiration of a mechanical breath, as long as your inspiration doesn't go 375 seconds longer than your I time, you're not going to cycle another breath. But because this is such a short period of time, it could be that, and I'll draw a waveform here once more, it could be that if this is your, it could be a patient-assisted breath or a patient-triggered breath. So I time set by your ventilator. But if your patient wants to inhale longer than that and they exceed this 375 seconds, it could actually trigger another ventilator breath. So the patient didn't actually want a full breath here, but they're going to get it because they've triggered the breath because their inspiratory flow has exceeded the trigger threshold on your ventilator of 3 liters per minute, if you're still at 3. And so the way around this is either, if you're recognizing that, is to increase your I time to try to give them more time to do that, or sort out why they're doing that. If they're in pain or some other discomfort, then it could mean that they simply need more sedatives or analgesics, and that could be the way to go too, especially if you see this on a regular basis. But if you see it occasionally, even on an occasional breath like this, it means an over-distension of alveoli, because you're going to get more volume. How much more volume you need, we don't really know, but you are going to get more volume with those breaths. And keep in mind, this is only functional if you're in pressure control. If you're in volume control, there is no early termination in a volume control breath. So in VC, works nicely in AC/BC when you are ventilating a patient who's well sedated or is breathing right along the ventilator and is happy with that, with the I times that you set. However, anything that, if they're inhaling for longer than the I time set in volume control, you're going to get this double cycle piece again. And if they're inhaling for shorter, if they want a shorter I time, they can't have it because there's no termination for a volume control breath, because the machine's goal is to deliver a volume, and it says, I need to deliver that volume within this period of time. So if you shorten the I time, the machine can't accelerate the flow to try to get that volume in. And it has no idea that you're going to do that shortening either, or your patient's going to do that. So leads to asynchrony with your patient. So bottom line in this is that there's a number of ways to deal with asynchrony, and more medication is not always the answer, but sometimes it is. And the other thing is maybe selecting another mode of ventilation for your patient. Perhaps they're a good candidate for PSV, because then they can tailor everything as far as the respiratory breath is concerned. If not, then perhaps try them in PC instead, and rather than in volume control. Although, and that's only when it comes to the LTV, because there really is no evidence that suggests PC or volume control, one or the other is better. Now, having said that, it reminds me that there was one question that asked about that particular case as well too. People who have a heterogeneous lung disease, so you have regional differences in lung compliance, we typically have ventilated those patients with pressure control. And the thinking behind that is that we're not putting a constant volume in that's going to overstretch alveolar units that are more compliant. I guess on the other side of it, though, is because you're generating the same kind of pressure, you're still going to get more volume change in those more compliant alveoli. And that's why some people who use volume control with ARDS patients might argue that there's no good reason not to use volume control over pressure control. Again, it comes down to what sort of pressures are you generating inside your system. So if you're not exceeding your plateaus of 30 and your pips of 30, then you can use your 6 to 8 mils per kilogram ideal body weight. There's a couple of things that I found in putting this presentation together, which I just thought of when I mentioned that last piece there. There's one article that was written recently that did a systematic review of literature that looked at mechanical ventilation in critical care units, and the article's title was, "Should we ventilate everybody at 6 mils per kilogram ideal body weight?" And the reason for them saying that was that most of the most of the studies that were done were ventilating patients at 6 mils per kilogram ideal body weight. So they're saying if that's what they're doing in their research, should be ventilating everybody at that kind of a volume. And it's not an unreasonable thing to consider. And I'm not suggesting that we do that, we change our practice, but I'm also not suggesting that, that I wouldn't necessarily do that if it was myself. So it seems like it's a reasonable place to land. But we have 6 to 8 mils to maneuver as long as it's with your ideal body weight. Which brings me to another point when it comes to the chart audits that I'm doing. There are a few charts where people actually record the ideal body weight. In asking some of your colleagues, people are saying, well, we're calculating it, and our tidal volumes are based on that. But when I'm pulling the metrics out of the charts, and when I talk about the metrics, it's simply that there are a number of characteristics from your charts which is in a document that I use and other auditors use to determine whether your chart is following a certain standard. And that standard is really what's laid out in your medical directive book. So, for example, the question is then, were the tidal volumes greater than 8 mils per kilogram body weight? And so this is total body weight. That's the first question. And typically that's no. And the next question is, was the ideal body weight calculated, and is the tidal volume greater than 8 mils per kilogram ideal body weight? And for most of the time I have to answer, no, the ideal body weight was not calculated, simply because it's not in the chart. So, and I'm not trying to give you more work or anything like this. But if you're thinking about it and calculating it, then write it somewhere in the EPCR, because then I can actually use that as evidence that, there's a standard across the province where we're calculating ideal body weight of our patient, and our tidal volumes are based on that. And so that will demonstrate for those that look at those statistics that we are using ideal body weight to determine our tidal volume. Okay. And there's one last thing that I wanted to mention this morning, or this afternoon. It feels like I've been talking for a long time, so it feels like it started this morning and now it's this afternoon. But I have a question for you, and this is where I'm at a bit of a disadvantage because I can't see any of you, and I can't really get your answer. Although, you know what? What's the delay? I know I said 40 seconds. What is it actually?
It's 15 seconds, so I can also pose the question.
Yeah, so those of you that have access to a laptop or a computer and can respond to this, I'm going to give you a couple of minutes to respond to this. So if I was to say to you, give me a definition for driving pressure.
Okay.
Then,
John Britton actually, he asked the question for you.
Okay.
I was just waiting for you to take a break, but he said, first, can you explain the newer way of using plateau pressure and driving pressure?
Oh, we just gave it away.
And the importance of numbers, and specifically the correct definition of driving pressure. Okay. So he's already posed.
Good question, John. Thank you. And you and I already had this conversation, so it's. I was actually hoping. Well, I'll just ask all of you. You can think about this in your own mind. If you, for most of your career, have thought of driving pressure as the difference. I'll write this down here. So if we were to perform an inspiratory hold, we would get a waveform that looks like this. So let's say that patient's on a peak of 5. Let's say that this is 30. The plateau pressure, let's say, is 22, and we have 0 down here. So let's label these pressure points. So let's A, B, C, and D. For most of my career, in fact, I'll admit to this, and if someone says, Mike, said you've been out of touch because for the last 25 years people haven't thought of driving pressure this way. Regardless, I'll be completely honest with you. Up until the last 2 years, this is exactly the way I thought of driving pressure. When people spoke of driving pressure, to me it meant the pressure from A to B. And keep in mind that the pressure from A to B is a product of the lung compliance and the airway resistance. And the reason why we perform inspiratory holds is that so that we can eliminate airway resistance and find out what lung compliance, like what static lung compliance is. So airway resistance, this portion of the waveform, is simply the pressure that it takes to push that volume of gas through the airways. So it's the resistance piece itself. The literature today, and I should be careful when I say the literature today, because there are people that may have read this earlier and have been thinking along this line for driving pressure for much longer. So, and then I'm really demonstrating the fact that I'm out of touch on this piece. The literature today, though, actually uses driving pressure as this pressure here. And what they're suggesting with that is that that's the pressure that the alveoli are exposed to in order to get them to receive the volume that you're delivering. So it's the pressure from your plateau to your baseline or your peak level, so C to D in this case. And what they're suggesting is that the higher this driving pressure is, the greater the risk is of lung injury. And in fact, there are some individuals that are suggesting that we should actually be using this driving pressure as our limits and make adjustments to try to reach pressures of 14 to 16 centimeters of water and no more than that. And so when you get higher than that, that's where lung injury starts to take place, because that's what your alveolar units are exposed to. Because this pressure here is, your alveoli don't see this pressure. It's somewhere, it's measured actually at the mouth as far as your ventilator is concerned, and it actually gets less and less and less as you get down your airways because it's a dynamic pressure. However, this one is the pressure that's throughout your whole airways and that your alveoli are exposed to. So as you start thinking about driving pressure, think about the difference from here to here. And interestingly enough, I'll give this now, the LTV maybe have been ahead of its time, because what does the LTV call this pressure here? And in fact, it calls it delta P. And when you perform an inspiratory hold with the LTV, I don't think that the people that designed the ventilator were thinking that this would be driving pressure. But because when you perform an inspiratory hold, it's all about static lung compliance. So they're actually giving you the pressure from plateau to peak, plus the ventilator knows what the volume is inside the chest. So let's just take a volume of 500 cc's as an example. And in order to get the compliance, the machine divides this 500 cc's by whatever the delta P is. And in this particular case, our delta P is 22 to 5, so it's 17. And 17 divided into 500, that's, I'm not going to try to do that in my head quickly for you. But nevertheless, that pressure, or the driving pressure, is the pressure that's most significant today when we talk about lung damage. So I'm not sure that there were a couple of pieces in Jonathan's question. I know that
so
answer.
He said there's a new way of using plateau pressure and driving pressure. And his specific question is around the correct definition of driving pressure.
So the definition of driving pressure in the context of what I was just talking about is from your plateau to your peak. And it's that pressure that the alveoli is exposed to. That's the important piece, because that's what the alveoli see. And that's what's going to damage the alveoli if it's excessive. So I hope that answered John's question. He asked also about the importance of the plateau piece. And the plateau, because it relates to that driving pressure, that's, the two are connected in that regard. Okay, so are there any other questions, Sean?
So Kelly Shepard wants just to clarify that plateau pressure minus PEEP equals driving pressure.
Correct. Yep, that's exactly it. Yeah. Now, it would be a shame that at this point, because we're into this now for an hour and a half, if I didn't show the P. Richard lung model and what it actually demonstrates. But there's one more question first. So.
Dennis asks, what is the difference then between MAP and delta pressure?
Okay. The mean airway pressure, or the MAP. So in the respiratory world, when I first started with Ornge, MAP meant mean airway pressure to me. And when I was listening to your colleagues speak about the physiology of patients, and they speak of MAP, I was confused at first when you were talking about numbers like 80 and 70, and going, those are really high MAPs. But when I discovered that you stole respiratory therapist mnemonic, or acronym, I mean, then I realized what it actually means. And I don't mean that in a bad way at all. I mean, I get it. So mean airway pressure, remember, is a function of a number of factors. So if we look at what we get with a mechanical breath, it's everything that's below the waveform. So we have PEEP and PIP. And So bear with me, Dennis, because I'm going to get to an answer to this, because you likely know these pieces here. So there's the I time, and then the expiratory time, and which translates into the respiratory rate. And there's also the shape of this waveform as well too. So that's your rise time, and which all contributes to the mean airway pressure. The mean airway pressure is the result of dynamic pressure changes. And so the difference between mean airway pressure and plateau is that the plateau measures a static pressure that is generated to hold a specific volume inside the chest. And the volume is what you chose as the operator to deliver to the patient. Whereas the mean airway pressure is part of all these dynamic features in here. And however, if you look in the literature for oxygenation, you'll come across something called the oxygen index. And typically, we talk about the PF ratio when we're talking about ARDS and trying to figure out how well someone's oxygenating. But the PF ratio is the PaO2 over the FiO2. So typically, we should have PO2, which is approximately 5 times what our FiO2 is. So breathing room air, the best PO2 that we could get breathing room air is 100, right? So 5 times 0.21 or 21. So if you have a person on an FiO2 of 1, theoretically you should be able to get their PO2 up to 500 if you got healthy lungs. It'll be somewhere between 400 and 500. However, this doesn't take into account all the pressures. All it does is take into account the FiO2. But these pressures play a part in how you get to your PaO2. And so the oxygen index not only looks at the FiO2, but it also looks at the mean airway pressure. So mean airway pressure and FiO2. And as a result, that's a better understanding of how much does it cost in the way of ventilation and to the lungs to oxygenate your patient. So if you get really aggressive in your ventilation because your patient is oxygenating well, then your oxygen index increases. And what it simply demonstrates is that you're having to use relatively aggressive ventilation parameters in the form of FiO2 and pressures and rate to get a reasonable oxygenation of this patient. And the higher that number is, simply says that the cost and to your lungs are going to be higher if you continue like this. And typically, in the literature, it talks about reaching certain thresholds with oxygen index and changing your ventilation strategies from moving from, in a critical care unit, from conventional ventilation to high frequency ventilation. And if you get OIs that are greater than 25 to 30, those people become candidates for ECMO. And so I hope that answers your question, Dennis, because you were asking about mean airway pressure and plateau. So mean airway pressure is a function of dynamic factors, whereas the plateau pressure is a static number. So the two of them don't really relate to each other. You can't look at one and say, I'll have to give some more thought to this. I was about to say you can't look at one and say the other one's going to be bad or it's going to be good. Actually, you probably can. So I'll take that back. Okay. All right, so lastly, if Paul's out there online, I want to give him the credit for his model. And what this simply is that there's a test lung inside of a water jug. On the back side of this is a manometer that has a blow-off on it, so I can regulate the pressure that's external to this test lung. And then there's another inlet here which allows me to put some pressure into the system, and the blow-off will regulate how much pressure. Okay? And in my case here, I'm using a cylinder of oxygen, but you could use a small CPAP machine or something like that, which would be more effective. But for the purpose of what we're doing, this will actually work. So what I want to get to in this is that the pleural pressure has a dramatic effect on what's going on in the lungs. So if you have and specifically, if you have a patient who has a large distended abdomen, which is as tight as a drum, that pressure is going to be pushing up on the diaphragm, and it not only restricts the ability of the lungs to expand in a downward fashion into the abdomen, it also restricts the ability of the lungs to expand against the pressure that's in the pleural space, because the pleural pressure will reflect that elevated abdominal pressure. And the way that is actually measured in critical care units is that an esophageal probe is put into place and measures esophageal pressure, which is a surrogate for pleural pressure. And if your pleural pressure is excessive, external to the lungs, so it's pushing down the lungs. It's going to affect your ability to expand those lungs. And so the demonstration of this is that I'm going to set the pleural pressure, or the pressure outside the chest lung, to 10 centimeters of water. Give no PEEP at all with the ventilator, and we can see what the chest lung looks like. So I hope that that shows up in the video clearly for you there. So I'm just going to bear with me for a second. I'll cut the ventilator up. Okay, so the honking sound that you hear, those of you from the CV4 days, sounds like the CV4, and it's exactly the same kind of principle. It's that gas that's trying to escape through a positive bleed valve. So right now, I've got the pressure external to the bladder at 10 centimeters of water, if you're able to see that. So that's 10 centimeters of water, and we have 0 level of PEEP, and we have a pressure control of 15. And you can see that the machine is struggling to try to get any tidal volume into this patient at all. So what I'm just going to do is I'm going to leave the pressure control of 15 alone, but I'm going to turn up the PEEP to 10 centimeters of water. So it'll take a couple of breaths for this to demonstrate itself. But what I'm asking you to watch is that the resting volume in the chest lung is actually larger when the PEEP levels are the same as the plateau pressure, or the pleural pressure. So you've got a larger FRC, and because your FRC is larger, you've moved the lung up the pressure volume curve. The lung's compliance is better as well too, and you can deliver a larger tidal volume just by increasing PEEP because you've improved the compliance of the lung. And you can see as well too that, and I'm not quite sure that happened, but our pressure external is 0 on this system as well too. So I'll have to see what's happened to my flow here. Okay, so we're getting back up to, we're getting closer to 10 again. Trying to be careful here not to let too much pressure build up in this, because to have this explode at the end of the presentation is not the dramatic finish that I'd be looking for. So the point again is that excessive pleural pressures without adequate PEEP can result in difficulty in generating a reasonable tidal volume to your patient. And you might ask then, well, you know what? I don't have the luxury of an esophageal probe in transport, and correct, and it's not done in every critical care unit either. The point is that, for me, is to get across to you is that if you have a patient who has an ascites with a large, tight abdomen, 30 degrees in the bed is going to get you some advantage as far as ventilating, but it's not going to do everything, especially because the abdomen is so tight. And those elevated pleural pressures, and you might be wondering, well, why does it take such high levels of peak inspiratory pressure to get a volume into this patient? It could be that your PEEPs aren't high enough. So titrate up your PEEPs, or give some consideration and discussion with the TNP to titrate up your PEEPs to counterbalance the excessive pressure of the abdomen. And you may discover that your compliance improves in that if you're in volume control, it takes less pressure to deliver your volume control breath. If you're in pressure control, you're delivering larger breaths for the same pressure control pressures. And you don't know exactly when you're going to have equal PEEP and equal pleural pressure, but just look for the best kind of pressures that you can achieve by making some of those subtle adjustments, and see whether or not then you can get below those pressure thresholds, which of 30 centimeters of water PIP or 30 centimeters of water for your plateau. Okay. And thanks again to Paul, the endorsement on the model. I think this is pretty cool. Like I said, I got up to one of the initial ed courses this past spring after having shown Paul the video, and it was simply, I was going to say, I'm going to post this video so that the class can actually see this. But when I got there, Paul had actually built one, so this was even better. So thanks, Paul. And that's pretty much the whole story for this afternoon. I thank you for sitting through the whole thing, and I hope that that it gave you something, maybe one or two things new that you maybe didn't know before. And if the rest of it simply reinforced what you were already doing, what you already knew, then that's also a good thing as well. Okay, thank you.